Okay, we have equipment assisting endodontic procedures. We are at slide number 42 now, ladies and gentlemen. We have our apex finders. So our apex finders, or rather apex locators, help us locate the apex of a tooth essentially. So some of them even have like audio stimulation. So once you've actually reached the apex of a tooth, then you'll hear like a tweet, 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 or a brightness. So some of them even have like graphic, if I can say, interpretations to help guide the dentist to actually find the apex of the tooth. So you know that whatever measurement that you got from that, you try not to go above that, so that you actually don't open the apex of your tooth. Then from there, we have heating units. This will also again depend on the practice where you are at. Heating units help heat things such as gutta perchas, can be also used for bleaching procedures wherever necessary. Okay, so that's what basically heating units do. We then also have endodontic handpieces. These are normally slow handpieces. Some of them have adjustable torque, so that the dentist has better control of how much speed or torque they require per procedure or per tooth. Endodontic handpieces essentially just mimic that rotary in and out motion that we normally do manually. So in other practices, they might actually just have endodontic handpieces instead of actually filing manually. I prefer filing manually because you have a greater sense of, if I can say, proprioception. Like there's greater tactility, like you can actually feel what you are doing, what you are looking for. But I think with time as well, other people prefer endodontic handpieces, but that's essentially its function. We then have vitality scanners. So vitality scanners check for the vitality of the tooth. Remember, ladies and gentlemen, we did say that they are prone to false readings. So whatever answer you get from the vitality scanner, you have to use it in conjunction with other tests to actually come to a conclusion. We then also have ultrasonic units. Not that common, but ultrasonic units help remove calculus or debris in and around the tooth. You can actually even remove items or restorations such as crowns, bridges, even posts, by making use of your ultrasonic unit. So they're quite useful in that regard. We then have our endodontic benders. So endodontic benders, ladies and gentlemen, they bend our files and our reamers and other such materials, like even our pesos, or even to basically conform to the curve or the shape of the canal that we are working in. So that's essentially the function of an endodontic bender. We then have dental microscopes. These are quite expensive, not that common. I've only seen them at academic institutions. So these microscopes, they help the dentist visualize the cavity from an early stage. Excuse me. So they allow for greater magnification, illumination, and they are also shadow free. So the dentist can see from, like I said, an early stage. So you can even see things such as fractures that may actually even affect the prognosis of a tooth. They are also very useful in teeth that are more posterior, they're more narrow, they're more curved, so that the dentist can actually navigate their way around them more effectively. So obviously, because you can see better, you'll actually even do better as a practitioner, and then decrease the likelihood of retreatments in the process. Then from there, we have our endodontic obturation systems. So these are systems that actually fill the canal to prevent any micro leakages. Speaking of that, I actually skipped a slide, sorry. So that's slide number 41. So that talks about our root canal sealers as well as cements. So root canal sealers, basically, ladies and gentlemen, that's like the material or the cement that you place around your gutta percha before you actually place the gutta percha into the canal, before you actually close that tooth. So these sealers can either be made out of zinc oxide, eugenol, calcium hydroxide, or even glass ionomers. Like there's quite a range on the market. So these sealers are used with obturating materials to prevent micro leakage in the canal. So in addition to GPs, they actually help seal the canal, if I can put it that way. Other people make use of, like how I was taught, you actually place the cement on the GP itself. Others place it on the spreaders or the endodontic pluggers that we just mentioned slightly before. But I've actually never seen anybody do that. It actually takes longer. And then they come in different forms. So we have our powders, liquids, pastes, and capsules. So from there, we're going to discuss the general steps in root canal therapy. So one, I think the patient is going to come in. Hi, Mr. Martin. Yes, so our patient's going to come in. You're going to do a medical history. You're going to do a dental history. So the patient then either is going to pay cash or medical aid. Sometimes a co-payment will be required in this instance. Then afterwards, we'll get the patient in chair. We'll talk to the patient. They're going to describe the pain, the type of pain, the type of tooth, or which tooth, is the one that is affecting them, that brought them to the practice today. Once that is done, ladies and gentlemen, we're going to take our pre-operative x-rays, our periapical x-ray, and then from there we're going to do some testing: heat, cold, vitality, or all of those things that we discussed now. Once we've come to a diagnosis, we're then going to explain to the patient, this is the procedure, how long it takes, blah 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 blah. If they consent, then we go forward to the actual clinical procedure. So number one would be then to administer anesthesia. So we're going to inject the patient or the affected tooth that we are going to treat, and then from there we're going to isolate the area. Normally, almost everyone will tell you that root canals are done with rubber dams. So we isolate the tooth using the rubber dam, with the rubber dam itself, the holder, the clamp, all that shebang. But that system is actually quite expensive and very time consuming, especially if you're dealing with like molar teeth in the maxilla and mandible. It's quite tricky. And remember, you're going to take 5 x-rays in this process, as I had mentioned earlier on. So you can imagine taking it in, out, in, out, in, out. Yeah. So some private practices, or a lot, you will see for yourself that instead of a rubber dam, they basically even use cotton rolls to isolate the tooth. It is not as effective, but it does happen. So I need you guys to be realistic on that level. And then from there, we are going to gain access to the pulp. Obviously, before you gain access to the pulp, you need to remove caries or any temporary restorations or all of that first before you actually go straight to the pulp itself. Okay, so yeah, so those are some of the things we're going to remove before we actually gain access to the pulp. So gaining access to the pulp, ladies and gentlemen, the dentist basically follows the morphology, or where we likely suspect the roots are. So if you know your dental anatomy, you should not struggle to find pulpal chambers. Then from there, you're going to locate your canals. Like I'm saying, it's those little dots that you're going to use your endodontic explorer. So once you think you've arrived, you just confirm by actually placing your explorer in the normally sometimes once you remove your explorer, the canal itself starts bleeding. So that's when you know that, yeah, I found what I'm looking for. And then from there, once you've located them, you're going to remove debris. You're going to actually, remember, it's a pinpoint, so to enlarge it, we'll be making use of our gate slidden. We'll be making use of our gate slidden, our slow handpiece, to actually open up that canal. And then once you can actually see it, then you're going to remove the pulpal tissue, okay, that's causing the patient pain. Then after removing pulpal tissue, you're going to actually enlarge and smoothen this root canal. Normally, by enlarging and smoothening, we would have taken a preoperative x-ray, if you guys remember. So we're going to make use of either our apex locator, or we're going to measure the millimeter on the x-ray itself. Once we've done that, we're going to take our K files and then keep them, measure the length on the ruler, place a stopper where necessary, and then we're going to start enlarging and smoothing our root canal. You do that by first irrigating. You do not place your file in having not irrigated before, having not placed irrigation material like your sodium hypochlorite or your sterile water into the canal before you actually start cleaning. So you're going to irrigate. So you're going to clean, place Milton, put in your K file, and then you're going to start cleaning, removing pulpal tissue, removing necrotic tissue, removing any and all soft tissue. And then you're going to place a temporary filling. Sometimes it depends on the tooth and how the dentist prefers to work. Usually root canals take 2 appointments. Sometimes you can just complete it in the 1 appointment. The biggest reason why root canals are not finished in 1 appointment is that if there are problems, like if a patient is feeling pain and they come back and you've completed it, there's really not much you can do. It's actually even harder to get all of that material out. So it's just better to get to finish cleaning, maybe put the patient on some medication if necessary, let them go home for a few days, let them come back and report if the pain and the discomfort and the swelling has improved. If it hasn't, you know that you need to clean more, check your working length, check all of those things before you actually go and fill that tooth. Okay, and then if you're happy with all of that, you're happy with your working length, you feel like the canal is actually adequately cleaned, you then are going to you're going to dry the root canal with your paper points. Remember the paper points that we discussed? Yes. Once we're happy, we're going to dry our canals with our paper points, and then we're going to take our gutta percha with the cement placed around it, and then we're going to actually obturate. So we're basically sealing our root canal. So we're going to seal it, making use of our endodontic pluggers to actually get in there, get all the material and the cement inside. And then once we have closed that off, then we're going to place our final restoration. So this could be a resin restoration. Sometimes you're going to have to do a post and core, or a post and core, or sometimes you'll put either a bridge or a crown, depending on what your ultimate goal is for the patient. And then from there, refer the patient to a general dentist for a final restoration, but we do all of that. Yes. And then sometimes, ladies and gentlemen, you would have done that entire procedure and then the patient still comes back with pain. So you assume you've removed all the periapical tissue, you've removed all the pulpal tissue, but the patient still exhibits pain, so now they come back to the practice. So causes of these: one, the abscess did not heal, especially if it was a large abscess and the patient actually took time to come back to the practice. The other reason is narrow or curved canals that were not treated. So sometimes some canals are just so narrow that you just feel like you keep filing, or you keep trying to access with your K-file, but it's just not successful. Some dentists maybe opt to just leave it, and then just by leaving it, it still has necrotic tissue that will cause pain, despite that you've maybe cleaned and have treated all the other canals. And then new filling, new decay along the new filling. So sometimes we have secondary caries that you guys may know of, and then they still get into our sealed canal, cause micro leakage, get to the periapical area, cause destruction to the periapical area. Then the patient comes back, and then from there, complicated anatomy, canal anatomy that went undetected. So sometimes, guys, you might think, let's say for example, tooth 1-6, you have 3 roots, and you're like, okay, I know tooth 2-6 has 3 roots, and therefore maybe I must expect 3 canals in there. And sometimes maybe on the mesiobuccal aspect there might be like a 4th canal, something to that effect. So now you've basically cleaned the 3 that you know of, but you didn't take into consideration that sometimes root canals have deviations where they have more canals than the number of roots that you have in a tooth. Okay, or sometimes that 1-6 can have like 4 roots, and then now you have 4 canals that you may treat. So maybe you just missed one, and then the patient comes back exhibiting pain and other issues. And then from there, other causes include the restoration did not occur soon enough after treatment. So sometimes maybe you tell a patient, okay, well, we're done with the first appointment, you'll come back for the second appointment in 3 days time. Then they'll tell you, maybe due to work or whatever obligations, now they go for like a week or 2 or 3 weeks, then they come back after so long. So now they've compromised all the work that you've actually done in the root canal. And so you can imagine all the debris, the saliva and everything else that they've been consuming, or the oral cavity has been subjected to. So now obviously that will compromise our results for our retreatment. And then sometimes the restoration becomes loose, cracked or broken and exposed to new decay. So sometimes you might place like a temporary filling, and the patient does not come back in time. Then obviously it would have compromised the work that you've done in the root canal. Sometimes, like I was saying, you actually place the final restoration and then it breaks or has secondary caries or something to that effect, which then causes leakage into that canal and causes problems for the patient again. So those are some of the causes for endodontic retreatments.